Welcome to Roadmap to Residency. Hello everyone, I am Abhiraj. Welcome to our Club 250 Matchmaker sessions. We will be running through a question with you guys to help you on your journey to a 250. So whenever you encounter a USMLE style question, the first thing that you need to do is to read the last line first, as I always say. Now, what histological findings are characteristic of celiac disease in this patient? A 28-year-old woman presents with chronic diarrhea, bloating, and weight loss. She reports that her symptoms worsen after consuming foods containing wheat. Endoscopy with duodenal biopsy reveals blunting of the villi, infiltration of lymphocytes, and elongated crypts in the duodenal mucosa. What histological findings are characteristic of celiac disease in this patient? Now, the last line have made this all very, very easy for us. They have already mentioned the diagnosis, but still, we have a 28-year-old woman who has a history of chronic diarrhea and bloating, which is typically malabsorption symptoms, and the patient has a biopsy findings of lymphocytes, infiltration, and elongated crypts, and is asking us about the histology of the celiac disease typically. So options we have like hyperplastic goblet cells with reduced lymphocytic infiltration, increased villus height and increased goblet cells, blunted villi, lymphocytic infiltration and elongated crypts, decreased intraepithelial lymphocytes and deep crypts, and normal duodenal mucosa. Now please pause the video and think what is the answer. So the histological findings characteristic of celiac disease in these patients are described in the answer choice C, that is the blunted villi, lymphocytic infiltration, and elongated crypts. The key findings of the celiac disease histology includes blunted villi. So the presence of blunted villi in the duodenal mucosa is a hallmark histological feature of celiac disease. Now, in individuals with celiac disease, exposure to gluten leads to the damage of the small intestinal villi, resulting in a flattened or the blunted appearance. The lymphocytic infiltration, that is the infiltration of lymphocytes into the mucosal layer of the small intestine, is another common histological findings in celiac disease. And these lymphocytes can be seen in the lamina propria. The elongated crypts in celiac disease, the crypts of the intestinal mucosa become elongated due to the increased cell turnover and reparative process taking place in response to the mucosal injury. The histological findings of all the malabsorption syndromes are very, very important for the USMLE step 1. But in this video, now we are going to discuss about some of the basics of the GI tract anatomy, histology, and a little bit about the GI physiology and all. So the GI anatomy starts with the GI tract layers. So the GI tract layers consist of the mucosa, submucosa, muscularis, and serosa. So MSMS. In the mucosa, there is the epithelium, lamina propria, and the muscularis mucosa. In the submucosa, that contains the submucosal gland and submucosal nerve plexus, that is the Meissner nerve plexus. And in the muscularis, there is the inner muscular layer. So muscularis should have a muscular layer and a myenteric nerve plexus or the back plexus. Now, you need to remember that Meissner nerve plexus is located in the submucosa, and the myenteric nerve plexus is located in the muscularis. Now, this concept is time and repeatedly asked in the USMLE step 1. And the muscularis also consists of the outer longitudinal muscle layer. So there is the inner circular muscle layer, and there is the outer longitudinal muscle layer. And the last one, or innermost, is the serosa. So talking about the animation to the histology. So in histology here we can see this is the tunica mucosa, this is the submucosa, this is the muscularis, and then we have the serosa. Serosa, tunica serosa is the peritoneum of the GI tract. Now, the layers of the gut wall inside to outside are the mucosa, submucosa, muscularis, externa, and serosa. So here in this picture that you have seen that from the mucosa towards the serosa. So mucosa, remember it as the mucosa is the one layer that is in close proximity with the lumen, with the food contents, right? Because you need mucus to keep the food lubricated. And serosa, it actually is the outermost layer of the GI tract. Now, the mucosa or epithelium, lamina propria, muscularis mucosa, submucosa contains the Meissner nerve plexus, muscularis externa contains the myenteric nerve plexus, serosa contains When intraperitoneal, it is called as serosa, and when it is a retroperitoneal structure, it is called as adventitia. Now, the ulcers can extend into the submucosa too. So the ulcers are typically in the mucosa layer, but it can extend into the submucosa. And also sometimes if it is very, very chronic ulcer, it can extend up to the inner or outer muscular layer. The erosions are in mucosa only. So this is the one difference that you need to know even in the surgery. Now, the frequency of the basal electric rhythm or the slow waves, which originate in the interstitial cells of Castle. These interstitial cells of Castle are in the highest number in the duodenum and in the least number in the stomach. So duodenum, ileum, stomach in the decreasing order. Now let's talk about the digestive tract histology, each and every structure of the GI tract. So first of all, we have the esophagus. So esophagus is a non-keratinized stratified squamous epithelium where the upper 1/3 part of the esophagus consists of striated muscle and the middle and lower 2/3 consist of the smooth muscle with some overlap at the transition. Now here we can see in the histology, the one is the lumen, the two is the stratified squamous epithelium, and then we have the lamina propria. After that, we have the muscularis mucosa. After that, we have some glands within the submucosa, and then we have the muscularis externa, where we have the circular and the longitudinal layer, and then we have the adventitia layer, right? Now, in the stomach, we have the gastric glands, and the parietal cells are eosinophilic or pink, and chief cells are basophilic. So this is a basic histology of the stomach. So here we have the mucosa, and then there is the submucosa, then there is the oblique, circular, and longitudinal muscles, that is the muscularis externa, and then we have this thin layer of the serosa. Now, talking about the duodenum and the jejunum, in the duodenum, there are villi and microvilli. And these villi and microvilli actually increase the absorptive surface. And the duodenum also consists of the Brunner glands, okay? Now, these Brunner glands are the bicarbonate secreting cells of the submucosa. So the stomach secretes acid. And when this acidic food particles comes towards the duodenum, you need bicarbonate to neutralize these acids. And these bicarbonate are produced or secreted by the Brunner's glands. And these Brunner's glands are situated in the submucosa. And there are the crypts of Lieberkuhn, and these crypts contain the stem cells that replace the enterocytes or the goblet cells and paneth cells that secrete the defensins, lysozyme, and the TNF factors. And also the duodenum consists of the ligae circularis, which is present in the distal duodenum. Now, in the duodenum histology, we can say these are the villas, and somewhere in between the small villas, the villas contains small microvillas, and this increase the absorptive surface area of the duodenum. And then we have the mucosa here, and then we have the submucosa. And here you can see in the submucosa, you have the Brunner glands. Now, these are the Brunner glands. You can see these bunch grape-like structures. These are the Brunner glands. And after the submucosa, you have the muscularis externa, and then you have the serosa. In the jejunum also consists of villi, crypts of Lieberkuhn, and ligae circularis. But the main thing about jejunum is that it gives a feathered appearance. Okay, and this feathered appearance is due to the ligae circularis, which are more prominent in jejunum. Okay, now whenever you give a patient an oral contrast and take an X-ray, and then you can encounter a feathered appearance. Now that feathered appearance is mostly due to the jejunum. Okay, and the ligae circularis, which are more prominent, also increases the surface area for the absorption. Sorry. So in the histology of jejunum, the mucosa of the small intestine is lined by the simple columnar epithelium, which evasinates into the villi, right? Now, the epithelium of villi is continuous with that of the adjacent crypts. The lamina propria of the small intestine forms the core of the villi and surrounds the crypts. The muscularis mucosa of the small intestine forms a thin layer. So in between the villi, there are the crypts, okay? The main thing that you need to understand about the jejunum is that the jejunum, the numerous amount of ligae circularis gives a feathered appearance with oral contrast. Now let's talk about the ileum and the colon. So the ileum has a villi pairs patches, which are typically the lymphoid aggregates, and the liquor circularis, which are present in the proximal ileum. So from the transition towards the jejunum to the ileum, in the proximal ileum, they also contains the liquor circularis. So that's why the when the liquor circularis are only present in the proximal part of the ileum does not give typically a feathered appearance like that of jejunum. And the ileum also consists of crypts of liver Crohn, and these are the largest number of the goblet cells in the small intestine. Now there are villi, and there are the goblet cells, and there are the most number of goblet cells are present in the ileum. Okay, now there are the villi, and these villi also consist of the goblet cells, and there are also the crypts between the villi, and there are the Peyer's patches. The Peyer's patches are the lymphoid aggregates which are present in the submucosa, and then you have the muscularis layer, the longitudinal, and the circular layer. The colon consists of strips of liver Crohn with abundant goblet cells, but no villi. So villi is absent in the colon. The villi is present up to the ileum. So colon, here we can see a section of the colon, the mucosa consists of crypts, but no villi. So here you can see the mucosa contains these small crypts, but there are no villi that you can see in the mucosa layers, okay? And there are also a lymphoid follicle in the mucosa layer in the colon too. And in the submucosa, here you can see the blood vessels and all, and the muscles in the muscularis layer. Now let's talk about the GI motility. Now, when you talk about the deglutition of the food, first of all, there is elevation of the tongue, then there is the posterior movement, so the elevation of the tongue, then there is the posterior movement of the tongue, and then there is the elevation of the soft palate, and there is the elevation of the hyoid, which opens the tract, and then there is the elevation of the larynx, and then there is the tilting of the epiglottis, which opens the tract for the food to be passed downward towards the esophagus. So there is upper esophageal sphincter. Okay, now from there, if the foreign body is there, then it can get stuck above the upper esophageal sphincter, and then the bolus just passes with the deglutition action of the esophagus. Okay, and then the lower esophageal sphincter opens, and the food goes towards the stomach. So at rest, there is no waves in the esophageal peristalsis, right? When the esophageal peristalsis manometry is done, there are no waves. But when you initiate the swallowing, then there is the peak in the esophageal wave pattern. And in the typical esophageal peristalsis, then you can see that there is the forward movement of the waves. You can see this wave is behind this wave, and then this wave. Now this represents the forward movement of the waves in the esophagus, and then there is the dilatation of the esophagus in the lower esophageal sphincter, and then there is the closure of the sphincter, which also gives a small peak. Now talking about the GI blood supply and innervation, the foregut is supplied by the celiac artery, and it is supplied by the vagus nerve. Okay, so foregut and midgut is supplied by the vagus nerve, and the hindgut is supplied by the pelvic nerves. Okay, and so the foregut is the foregut. So you need to understand from where to where is the foregut. Okay, now these are the structures that are supplied by the foregut, but the foregut structures, they generally ask you questions about which structure developed from the foregut and what will be the blood supply of that foregut structure. So foregut is the celiac artery, midgut is the superior mesenteric artery, and the hindgut is the inferior mesenteric artery. So this is one information that you always need to know and is frequently tested from the GI blood supply and innervation. Now let's talk about the enzymes and cells of the stomach. Okay, now in the stomach, you have the parietal cells, the chromaffin-like cells, the chief cells, the G cells, the mucous cells, the D cells, the I cells, S cells, K cells. Now, when you just look at this picture, you can get confused. So we will first look towards the text, and then we will come again back to this picture. But first of all, let's revise something about the GI, the stomach histology. So there is the gastric pit, there is the upper glandular layer, and there is the deep glandular layer, and then there is the muscularis layer, and there is the submucosal layer. Muscularis mucosa, and there is the submucosal layer. And here we can see, if we just zoom in apart, then you can see this is the surface epithelium. Then you have the parietal cell here. This is the mucus secreting mucus cells. These are the chief cells, and these are the enterochromaffin-like cells. Now, let's do one question before we move forward. So, which of the following mechanism is most likely responsible for the elevated gastrin levels in this patient? So, 45-year-old male presents with recurrent episodes of abdominal pain, diarrhea, and peptic ulcers. Endoscopy reveals multiple gastric and duodenal ulcers. Lab studies show elevated fasting serum gastrin levels. Which of the following mechanism is most likely responsible for the elevated gastrin level in this patient? So, the question is asking us about the mechanism behind the elevated gastric level. So inadequate gastric acid secretion, chronic use of PPIs, infection with Helicobacter pylori, gastric outlet obstruction, elevation of somatostatin levels. So the most likely explanation is elevation of somatostatin levels because the patient presents with recurrent abdominal pain, diarrhea, and multiple peptic ulcer, which are the triad suggestive of Zollinger-Ellison syndrome. In JDS, there is the elevated serum gastrin and elevation of somatostatin. So when there is elevation of somatostatin, the gastrin secreting tumors, that is the gastrinomas, they typically arise from the pancreas or the duodenum, and these tumors can produce the somatostatin. Now, it is a hormone that inhibits the release of gastrin. Now, in response to the elevated gastrin levels, somatostatin production is stimulated, and in an attempt to regulate the excessive gastric acid secretion. Now let's talk about the G cells, D cells, and all. What were those ulcers that were producing the symptoms, that were producing the enzymes and all? So the gastrin is produced by the G cells of the stomach, and these are present in the antrum, antrum of the stomach, and the duodenum. And the somatostatin are produced from the D cells, and the D cells are present in the pancreatic islets and the GI mucosa. So the action of the gastrin is to increase the gastric acid secretion, the growth of gastric mucosa, and the gastric motility. Now, these actions and regulation are very, very important. And the regulation is that when there is stomach distension or alkalinization, then the gastrin secretion is increased. Or when the pH is less than 1.5, then the gastrin secretion is decreased. Now, we need to also know that when there is the chronic PPI use, there is increase in the gastrin secretion. In the H. pylori infection, there is increase in the gastric secretion, and also in case of gastrinoma, there is increase in the gastrin secretion. The somatostatin are the cells that decrease the gastric acid secretion, and pepsinogen secretion. And there is decreased pancreatic and the small intestine fluid secretion, decreased gallbladder contraction. So when there is increased somatostatin, then that will lead to the stasis of the bile in the gallbladder and that can lead to the gallbladder stones. And then there is a decrease in the insulin and glucagon release. If there is increased acid, then the somatostatin secretion is increased. Also, when there is when there is the vagal stimulation, then that decreases the somatostatin secretion. When you compare between the regulation of the gastrin and somatostatin, so when there is more acidic environment, then the gastrin secretion is stopped and the somatostatin secretion is increased. Now, there inhibits the secretion of various hormones, and also the octreotide, which is an analog used to treat acromegaly, carcinoid syndrome, VIPoma, and various cell bleeding, is also somatostatin only. Cholecystokinin are secreted from the eye cells of the duodenum and the jejunum, and these increase the pancreatic secretion and increase the gallbladder contraction. Now, if there is decrease in the cholecystokinin, then again the patient will suffer from gallbladder stones. Secretin are secreted from the cells of the duodenum, and these increase the pancreatic bicarbonate secretion, and these bicarbonate neutralizes the gastric acid in the duodenum, allowing the pancreatic enzymes to function. The glucose-dependent insulinotropic peptide are secreted from the K cells of the duodenum and the jejunum, and these are when there is these decrease the gastric acid secretion and increase the insulin release. And these are generally produced increase in amount when there is increase in the fatty acids and oral glucose. So that's why glucose-dependent insulinotropic peptide, also called as gastric inhibitor peptide. Motilin is released from the small intestine, and this produces the migratory motor complexes. That is, they increase the migration or the peristalsis of the small intestine. The vasoactive nutritional peptide are released from the parasympathetic ganglia in the sphincters and the gallbladder and small intestine. They increase the water and electrolyte secretion in the intestine. and they also increase the relaxation of the intestinal smooth muscle and sphincters. In the case of VIPoma, that is the VIP secreting tumor, which are associated with the watery diarrhea, hyperkalemia, echlorhydria. So you know that VIP is involved in the water and electrolyte secretion in the intestinal lumen. So whenever there is increase in the VIP, then obviously the patient will have a watery diarrhea because there is increase in the water in the lumen. The nitric oxide, they increase the smooth muscle relaxation. Okay, whenever there is a nitric oxide involved, it generally causes the relaxation of the blood vessels as well as the lumen and all because of the smooth muscle relaxation, and also in the lower esophageal sphincter. The ghrelin is secreted from the stomach, and it is increasing the appetite. Okay, and it is increased in case of fasting state, and it is decreased by the food. So ghrelin will cause the growing of the stomach. Now, talking about some of the secretory products of the stomach, there are the gastric acid, intrinsic factor, pepsin, and bicarbonate. The gastric acid is secreted from the parietal cells of the stomach, and they decrease the stomach pH. That is, they make the stomach environment more acidic. Whereas the intrinsic factor is released from the parietal cells, and these are the vitamin B12 binding protein substances. Okay. Now, the gastric acid and the intrinsic factor are increased by the histamine level. When it is increasing the histamine level, then the gastric acid secretion is increased, and it is decreased by the somatostatin level. The pepsin is released from the chief cells of the stomach, and they help in the protein digestion. So P for P, pepsin helps in protein digestion, and the secretion is increased by the vagal stimulation. The bicarbonate are released from the mucosal cells, okay, and they neutralize the acid as we have discussed earlier. Now, talking about basic about the digestion. So in digestion, there are many enzymes involved, but the most important enzymes are the pancreatic enzymes. And so these are the alpha amylase, lipase, proteases, and trypsinogen. The alpha amylase is generally involved in the starch digestion. Lipases for lipids, so fat digestion. Proteases for protein, so P for P, protein digestion. And trypsinogen are converted to active enzyme trypsin, and they are involved in the activation of other coenzymes and cleaving of additional trypsinogen molecules into active trypsin, which is a positive feedback loop. And these are converted to trypsin by enterokinase or enteropeptidase. So generally, the question tells you that the trypsinogen is converted to an active compound or active substance by which of the following enzymes. So that enzymes are enterokinase and enteropeptidase, which are produced from the cross border of the duodenum and the jejunal mucosa. Now, little bit about the carbohydrate absorption. So only the monosaccharides, that is the glucose, galactose, and fructose, are absorbed by the enterocytes. Okay. Now the glucose and galactose are taken up by the sodium glucose transporter one, which is a sodium dependent transporter. So the glucose and the galactose are transported through the sodium glucose transporter. The GLUT5 is used to transport the fructose. Okay. And we already know about one test that is called as the D-xylose test. When the simple sugar that is passively absorbed in the proximal small intestine, the blood and urine levels decrease with mucosal damage, and they are normal in the pancreatic insufficiency. So when we administer the patient a D-xylose, okay, so D-xylose is a simple sugar which is passively absorbed in the proximal small intestine. Okay, they do not need an active transport. Okay, and the blood and urine levels decreased with whenever there is the mucosal damage. Okay, and when we give the patient a D-xylose, then that cannot be absorbed through the mucosa, and ultimately the blood and urine levels of the D-xylose will decrease because it is not getting absorbed, and that tells us that the mucosa is damaged in the patient, but the D-xylose is generally normal in case of pancreatic insufficiency sort of individuals, because it is generally involved in the passive transport, so they do not need any enzymes from the pancreas and all. So even if the patient has pancreatic insufficiency, he or she will have a normal D-xylose level in the blood and urine. So the basic idea is whenever the patient is having mucosal damage, then the D-xylose level will decrease because of the decreased absorption. But whenever the patient is having pancreatic insufficiency, the D-xylose level will be normal because it is not dependent upon the pancreatic enzymes for its absorption. Thank you for watching.